So as a committee, we worked hard to get the right people to be speaking to us today. Our first presentation is going to be a cancer update from the National Cancer Institute. And who better to do that for us? And she wanted to be here, but she wasn't able to be, but she's going to be able to be on your screen, and then she will be available for question and answers. Her name is Katrina Goddard, and she is the director of the Division of Cancer Control and Population Sciences at the National Cancer Institute. So we're getting this information right from the top. Please join me in listening in.
Thank you so much for the invitation to be here. I am really excited to be part of your meeting and have the chance to work together with you for the partnership in Rhode Island. So today is actually the 1-year anniversary when I became director for the Division of Cancer Control and Population Sciences. So I'm really excited to spend this time with you today. And the next slide. The National Cancer Institute leads, conducts, and supports cancer research across the nation to advance scientific knowledge and help all people live longer, healthier lives. We're really excited to welcome Monica Bertagnoli. She is beginning her tenure as the first female director of NCI. And we're really excited to work with her on her vision for cancer research going forward. The next slide. So this is data that comes from some resources developed by our division, the SEER registry, and really illustrating one of those disparities that the prior speakers mentioned, namely that Black Americans have the highest rate of cancer mortality. And although this rate is declining for almost all populations, I did not include Native Americans and Alaskans in this slide, which is the one population where it's not declining. There is still a gap that remains that we need to address. The next slide. Not only do we see this disparity in mortality, but also in the exposure and burden of modifiable risk factors. We see disparities in who is screened and the stage at detection for cancer. We see disparities across different populations in cancer incidence and finally in cancer survivorship. So we need to really think about how to address health equity in all of these ways if we really want to achieve an equitable future for our population. So I want to start off with just saying a little bit about what our division is currently doing in terms of research on health disparities. And we code our research portfolio in a couple of different ways. The first is looking at health disparities. So these are studies where there's at least one specific aim that is a comparative study based on one of these factors, such as gender, age, race, ethnicity, etc. We also code our portfolio in terms of whether the population that is focused on in the research is a medically underserved population. And then finally, looking at the combination of both of those groups. And the next slide. So this really is predating when I joined NCI. So I get to really be proud of the work of the division to really increase the portfolio in health disparities research in our division. And as you can see, almost about 75% of the research that we currently fund has at least one specific aim that is focused on health disparities. And we're really proud of this work that's happening, and we think this is going to make a difference in health equity in the future. And the next slide, this is looking at the portfolio in terms of whether the research is focusing on underserved populations. And in this analysis, you can see 35% of our portfolio has 100% of the specific aims focusing on underserved populations. And this is really crucial to advance health equity. As was mentioned already today, we need to ensure that we tailor our approaches and make sure that the ways that we implement our interventions really work for specific populations. And so having portions of our research that are solely focused on these underserved populations is really helping us to ensure that the needs of those communities are met. The next slide. So in addition to race and ethnicity, we focus on disparities in several different ways, and I want to highlight a few. One is what we call persistent poverty areas, and these are defined at a census tract level. So this is a characteristic of the population, not of an individual. And in these areas, there has been 20% or more of the population below the poverty level for the last 3 decades. So there is extensive poverty within the community. And I think this has affected the resources available to the community and to the individuals living in those communities. And you can see highlighted here in red are the counties that meet this definition for persistent poverty. When you make this definition at the census tract level, it actually increases the communities that are meeting this definition, and particularly it picks up some more metropolitan areas where there are pockets of the metropolitan area that have had persistent poverty. And the next slide. And this is just to highlight the National Cancer Institute annual plan, and each year 4 areas are focused on, and just to point out that persistent poverty was selected as one of the focus areas for this year. And so this really has attention beyond our division, but at the highest level of leadership at NCI. The next slide is looking at rural and urban disparities, and these are some screenshots from our website. So I encourage you to go to our website and explore around. There's a lot of data there that you can take a look at that really is showing some of the disparities in cancer incidence and mortality that we see between rural areas and urban areas. And so this is another type of disparity that we focus on within our division. And finally, the next slide is a more recent area of focus for our division on sexual and gender minorities. And this past year, we have really been trying to stimulate research in this area. And we funded 13 administrative supplements to cancer centers, and really happy to report that the Yale Cancer Center was one of the 13 awards that we made. And these cancer centers are going to be working together over the next year to study how to implement standardized sexual orientation and gender identity measures so that we can really start to have better information about health outcomes for this population. So the next set of slides, I'm going to describe some of the ways that we focus our research to address health disparities and health equity. And so the first example is the SEER expansion. So in 2021, we actually increased the population to about 50% of the US population, which is now covered in the SEER registries. And this really particularly focused on expanding our coverage of racial and ethnic minority populations. So particularly for the Hispanic population, there was a much bigger increase in the proportion of the Hispanic population that is covered through SEER. So that increase was 25% and now covers 69% of Hispanic individuals who have a diagnosis of cancer in the United States. So this is really going to allow us to have a better picture of the situation for different racial and ethnic populations and be able to monitor and see these different patterns over time and have better estimates of cancer incidence and mortality for populations. The next slide, as you know, the United States population is increasing in diversity, and it's really changing the demographics of our population. And the next slide is focusing on new cancer cohorts that really are focused on increasing the population that is included in the research that we do. And this is two examples. One is on survivor cohorts, and the other is on environmental exposures and cancer risks. And these are all brand new cohorts that have been funded in the past few years that are just getting started in their recruitment. And they're really focused on increasing the diversity of populations that are included in our research. And this is going to have an important impact on our ability to evaluate risk factors that are important for these populations and to understand the etiology and differences across cohorts in terms of causes of cancer, and for the survivors being able to look at different survivorship in different populations and be able to tailor our analyses for those different populations. The next slide is an example from our behavioral research program that really focuses on modifiable risk factors, including tobacco, diet, alcohol, UV exposure, and HPV vaccination. And we recently had a funding opportunity that focused on rural-urban disparities in these behavioral risk factors for cancer. And so this is just an example showing how we're focusing on health disparities as part of our behavioral research. The next slide I put in here just from looking at your state cancer plan and knowing that you are focused on lung cancer screening. I wanted to bring to your attention the SCALE collaboration. which is research that is looking at incorporating smoking cessation into the lung examination for cancer screening. And I think this is something perhaps for you to consider in your program within your state, whether it might make sense for you to link smoking cessation to that lung cancer screening as an opportunity or moment in time when patients may be open to that conversation about smoking cessation. The next slide is an example from our healthcare delivery research program. And this is a program that was funded through the Cancer Moonshot several years ago. They're almost done with the analyses and being able to report out the findings from this program. So I know we're all looking forward to seeing the results from this program. But this is really looking at accelerating colorectal cancer screening and follow-up through implementation science, and really focusing on underserved populations, particularly racial and ethnic minority populations and people living in rural or difficult to reach areas, and trying to address the low colorectal cancer screening rates in those populations. So we're really excited to find out the results and learn if there is any information from these studies that can help us to improve colorectal cancer screening rates for these underserved populations. So that is the end of my examples from the research that we're doing at NCI. And I wanted to now turn to the question that was raised to me about how the Rhode Island community and its coalition can achieve health equity in cancer care locally. And so I just want to speak to this question in a few slides. And broadly speaking, I think the strategies that I just showed to you are in these 4 areas. First, whether health disparities are measured and monitored. So that is similar to the SEER registry example, where we need to make sure that we're actually capturing data on all the populations. And I read through your state plan, and I see this is also part of the plan for how do you capture data within your state as well. The next area is who is included. And so that example from our work was on the cancer cohorts and ensuring that we have diverse populations in those cancer cohorts. And I think there is also an intention within your cancer plan to ensure that all populations are able to access research opportunities. The next area was how interventions are tailored so that they are specific to the needs of individual populations. And finally, what barriers are addressed? And I think healthcare can be a maze for all of us to figure out how to navigate. And it's more of a maze for some people than others. And we need to make sure that we're actually addressing the barriers so that we can meet people where they're at and meet their needs. The next slide, I just want to bring to your attention the state cancer profiles, which is one measure that you can use to look at how your state is doing. These profiles are created by NCI and the CDC. This is just a screenshot of part of the profile for your state. And honestly, looking at this profile, I was very impressed with how Rhode Island is doing across many different areas. But one area that I really want to highlight is diet and exercise. where you can see on this slide that actually Rhode Island is doing better than the US as a whole, but I think we still need to say that many of these measures are unacceptably high in terms of the proportion of the population that is obese, or unacceptably low in terms of the proportion of the population that is actually eating fruits and vegetables every day. So I think there's still work to do in these areas. And this next slide shows that in the US as a whole, we are not meeting our Healthy People 2030 target. And in fact, the situation is moving in the wrong direction. And so I think this is something for us to really be paying attention to. I want to highlight that on our website, we have a database for evidence-based cancer control programs. And I'm just highlighting 2 examples of programs that you can find that are related to obesity. In these 2 particular examples are evidence-based programs. And if you go to the site, you can find out a lot more information about the programs, including how to access materials and other information about the programs. Next slide. Our division also produces resources about implementation sciences. And so this is a practice toolkit for practitioners. And hopefully information available in this toolkit may be of use to you as you're thinking about the programs that you want to implement within your state. The next slide is additional information that is developed by our division on research practice partnerships and providing more information about working together to improve programs. The next slide is about the Comprehensive Cancer Control National Partnership. And there are 5 areas that the National Partnership is focusing on. But one of the areas I particularly want to bring your attention to is resources for state level partnerships in terms of improving the partnership at your state. So I think this is a good resource for people to look at and think about whether there are any opportunities that you can learn from this national partnership in order to improve how things are going in your state. And finally, I'm happy to take any questions.
Thank you, Doctor. That was as informative and thorough as anything could be in 30 minutes. So if you have questions, we have 2 microphones. If you're in this room, and you can just step up to a microphone to your left or to your right. And we have a few minutes for questions. If you are on Zoom, I hope you know how to get into a chat room where we have somebody monitoring that. So if you have a question for Dr. Goddard, please feel welcome to ask those questions. But what a wonderful presentation. It's so good to know how much is being done at the National Cancer Institute and the work that they're doing, and to know how well they're monitoring our state.
Jim, I have a question for Dr. Goddard. Dr. Goddard, thank you. That was really very, very helpful and useful information. My question is, can you comment on the recent study out of Oslo about colorectal screening, doing colonoscopies, and some of the controversy that's come up about it? Thank you.
Yes, great. Thank you for that question. So I think that there has been some recent press that I think is potentially concerning, that it might discourage people from having colonoscopy because it appears to suggest that colonoscopy is not as effective as we had all imagined it to be based on a recent randomized clinical trial that was done. There have also been some recent commentaries, and one I'll point to in the New England Journal of Medicine that just came out discussing that study and why maybe we should have a little bit of caution in interpreting the results of that study. And so some of the factors that were raised in that commentary include that only 43% of the individuals who were invited to have colonoscopy actually received a colonoscopy, and that it can take longer than 5 or 6 years for a follow-up for us to really be able to see a mortality difference. I think the message that we really need to take from this study, for me personally, is that there are very different ways that we can perform colorectal cancer screening. Colonoscopy is one of those ways. But really, it's important for the patients to actually receive the screening in order to get the benefits. And so we need to think about all the tools available to us in terms of colorectal cancer screening and try to reach as broad a proportion of the population as possible.
Well, thank you, Dr. Goddard. We've kind of run out of time for this session, but thank you so much for being available to speak to us and share that information.
Great, thank you.